topics to you. Those are biliary atresia and anterior abdominal wall defects. Actually, both of these are very vast topics in their own and may need 2 to 3 lectures to explain in detail. I'll try to cover as much as possible in this very lecture. So, firstly, starting with the biliary atresia. This biliary atresia, as the name suggests, it is the condition where there is a defect in the biliary tree. As you can see, this is a diagram of a normal biliary system. So if and atresia means absence. So if any part of it gets absent, most commonly this porta part or the CBD part, then this is the extrahepatic biliary system. This is the intrahepatic biliary system. So if there is damage in either of these, then we have a condition called biliary atresia. So once there is any damage in the biliary outflow tract, then subsequently the inflammation sets in, which later leads to fibrosis, and then there can be liver failure in the severe cases. So this biliary atresia has a prevalence of 1 in 10,000 to 15,000 live births, mostly seen in the male patients. There are most commonly there are 2 types, which are fetal and acquired. The fetal one usually presents very early in the course of time, and these children have jaundice since the birth, and they don't have any jaundice-free episodes, and they are mostly associated with other congenital anomalies and have a poorer prognosis. While the acquired one, they usually present after 2 to 3 weeks of life, and there is a progressive inflammation. So there will be an interim period where the parents may say that the child was jaundice free. So usually these children present with jaundice, which is from the birth and is gradually progressing. The other associated features are they have pale colored stool, high colored urine, which is a feature of obstructive cholangiopathy. They also have abdominal distension, which is due to the hepatomegaly and a splenomegaly. Other things which may be present are the dilated veins on the abdomen. So when a child presents to you with a jaundice, you have to find out whether it's a surgical jaundice or not. So for mostly this surgical jaundice have a presentation as that of obstructive jaundice, where we need to remove the obstruction and to restore the biliary outflow tract. So the most common causes for surgical jaundice are biliary atresia, choledochal cyst, bile duct perforation, and inspissated bile duct syndrome, of which biliary atresia forms the major chunk. So when a child presents to you with a neonatal jaundice or a jaundice in the infancy, so first of all, what we need to, how we go about it is first we go for a blood investigation to find, and there we do liver function tests, liver enzymes, so that we find out whether it's an obstructive system or not, and also GGT. GGT is very sensitive marker for EHPA. Simultaneously, we have to also do the torch profile so as to rule out any infective pathology. Also, some people say the torch infection can be one of the cause for this biliary atresia pathology. The other tests, which are very important tests, are biliary ultrasound, HIDA, and MRCP. In the biliary ultrasound, we have to look at the liver echo texture, the triangular cord side, which is there due to the fibrotic band of at the porta. And also we have to look at the gallbladder motility, where we firstly bring a child pre-feed, and then we look at the when the child is fed, and then again we take a scan, and then we look whether there was some motility in the gallbladder, whether it has increased in size or decreased in size, which gives us which is an indirect marker of the continuity of the biliary tract. So in biliary atresia, the biliary motility is almost absent. In very few cases, you can find that even in TRAW, that the gallbladder is present and is functioning. The another important test is HIDA, which is in the present time is done with a mebrofenin. So this test is a nuclear medicine study. It is done under the nuclear medicine setup, where we do this test post priming with phenobarbital. Phenobarbital is a choloretic which initiates or allows the biliary flow or bile generation, and then allows the biliary flow, which allows us a better visualization of the bile drainage in the hydra scale. So these two investigations specifically have their specificity of more than 90% sensitive, more than 90%, and sensitivity of around 95% for biliary atresia. While there may be some cases where we may find cyst at the porta. So for those cases or any dubious cases, we need to go for MRCP, which is which provides us the 3D configuration of the porta system. The other tests which are used depending upon varying upon the institutional policies are liver biopsies, peroperative cholangiogram, and ERCP. Some centers also go for another one invasive procedure, which is serial dilatation of along the duodenum, which is mostly done in the Japanese center but not in India. The liver biopsy is not of much importance in Indian setups because the children present to us very late, mostly beyond 3 months of age, 4 months of age, where all the settings or the biliary cirrhosis is already settled. So there may be very few centers or very early cases where to make a diagnosis on the histopathology, liver biopsy is being done. Peroperative cholangiogram is an investigation which is done on table, on OT table, where a small catheter is being placed along the gallbladder, and in that it is seen whether what kind of bile is there. If it is a white bile, that means that suggests there has been no flow from the liver to gallbladder, so there has to be some atretic segment. And if it's even if it's a white bile, or sorry, even it's a normal bile, then also we do a study via that to trace the entire length of the biliary channel. And this is also one of the confirmative tests which is done on table and can be done in cases wherever there is a doubt. So how we go about it is just we look in the blood whether there is a direct hyperbilirubinemia or there is symptoms of obstructive jaundice. Then we go for ultrasound imaging, where if we see a positive cord sign, then we are more or less sure that there is some pathology associated with atresia. Then the cholangiogram can be done, and ultimately the child will need a surgery. Similarly, even if the triangular cord sign is negative, some centers go for liver biopsy or simultaneously peroperative cholangiogram. And if that are suggestive of biliary atresia, again one will need surgery. So the other conditions which may be creating doubt is another important, the neonatal hepatitis, for which one needs to observe and go for medical management. The commonly used classification is a Kasai's classification for biliary atresia, where they have a proximal, they have a distal variant, proximal variant, complete CBD association, and along with intrahepatic. So if a jaundiced infant presents with pale stool, so the most common time period which is suggested is of 60 days. And the another salvageable period is of 90 days. So if a child comes in early period, then we have a good chance to save these livers, and they can undergo portoenterostomy. While beyond 90 days, the liver would have gone so much damage and would be so much cirrhotic that the child will ultimately need a liver transplant. So it is just a visual, what you can say, a treatment plan which can be followed at various centers. Like if a child presents early, then the child can be taken up for surgery, can be taken up for operative cholangiogram and the liver biopsy. And if no tree is visualized, the biliary atresia is confirmed and child has to undergo photoenterostomy. While if the tree is patent, then we have to look for other causes. Another important causes in these kids is the inspissated bile duct syndrome, where a ball of bile becomes saturated and blocks the CBD. Another, if these kids have present very late, then we also look at their liver functions. If they are doing fine, then we may give a trial of the entire setting and the child may undergo Kasai's photoenterostomy. While if the child had deranged liver functions, there is ascites, cholangiopathy, associated pulmonary hypertension, then the child should better be worked up for liver transplant. The most common procedure which is done in these patients is Kasai's photoenterostomy. Actually, this surgery may not be the definitive surgery. Child may need a liver transplant, which is usually 1/4 or 1/3 of them require the liver transplant later in their life. But even in the early stage, where not in India, but elsewhere also, they have limited resources and liver transplant cannot be provided to everybody. So just this procedure is mainly a bridging procedure, and it has been noted that many of the children who underwent this procedure can do very good as much as to their adulthood. So what we do in Kasai's photoenterostomy is that when we see the absent biliary tree, so in this we take a loop of a small intestine and make a roux loop of it. So in roux and wire loop we call it. So we take this loop to the base of the porta, from where we allow a channel which freely drains the bile to the intestine. The remaining is the proximal part of the bowel is then attached to this roux loop. So this makes a kind of Y, and this is commonly called as roux and Y, ROUX-Y. So this is a photoenterostomy, where the porta of the liver is attached with a part of intestine. So what are the other complications even in the post-op period is the most common of them being cholangitis. These children can repeatedly present with the cholangitis, where they may have high-grade fever, jaundice, abdominal pain, abdominal distension. So mostly this is managed with medically. This can be managed, and the child may need a course of steroids, and which has to be tapered along the period of their treatment. The another important is the cholestasis. As I've already told that at times there can be blockade along the drainage site. So these kids are usually given UDCA, which allows the biliary flow. They are being given phenobarbital or the other choleretics, which allows the formation, and they make so much amount of bile in the liver, which allows easy flow of the bile to the intestine. The portal hypertension is another important associated complication, sequelae you can call, or the in the case of biliary atresia. It may be present pre-operative or may come after the surgery as well. So the main concern with the portal hypertension is that with the variceal bleeds. Another important feature is ascites. When these children have already damaged livers, so the most common thing that we see with the liver failures is ascites, which can be seen in these patients, and in the post-operative period they may have a copious amount of fluid coming out from their brain. Another important sequelae which are seen with these children are hepatopulmonary syndrome and hepatorenal syndrome. These children are usually poor on nutrition, and if the obstructive component is there, then the children may again and again present with pruritus or continuous itching along the body. Very few cases have documented, the hardly 0.1% cases have documented malignancy in the liver. So, if these children are operated in early period, they have a better prognosis in the later life. However, if they are delayed or present very late, then the liver has already gone under too much stress or is already damaged. So to retrieve that liver is very difficult, and they ultimately need liver transplant. Even with the Kasai's portoenterostomy, they may require recurrent admissions owing to the components of liver failure. So it has been noted that around 20 to 30% of children with biliary atresia can have a normal or may be near normal in their later life, provided they present early and have a good liver function at the time of their presentation. So here I am done with the biliary atresia. Another topic that I have to cover is anterior abdominal wall defects. So there are various abdominal wall defects that have been seen, most commonly being omphalocele and gastroschisis. Omphalocele is also called as ex-omphalos. So these can present as a lateral fold, which is the most common variant. It can come as a cephalic fold, or it can come as a cephalic fold, which are very rare variant, but have a very drastic sequelae or presentation. Then umbilical cord hernia, which is also is a very rare presentation, but is a documented part. Ectopia cordis thoracis is also one of the component or one of the type of anterior abdominal wall defect. So overall incidence is 1 is to 3,500 live births across the globe, and male is to female ratio is 1 is to 5 is to 1. So what happens? The abdominal wall is formed by the somatic and splanchnic layer of 3 folds, which is cephalic, which comes from the superior part of the fetal development, lateral, the two other folds that come from the sideways, and caudal, which comes from the inferior part of or the distal part of the fetus. So when all these 4 layers meet in the center, then they form abdominal wall. So if there is defect in any of these, or in the migration of these folds, then we get the defects with the anterior abdominal wall. So simultaneously, there are various theories which are proposed. Like if any of the fold is missing, then the child may have this anterior abdominal wall defect, or if the common point where they meet fails to develop, then they may have a abdominal wall defect. Another important point here is that during the time of gut rotation or gut formation, what happens is by the 6th week, the entire gut is outside the body of the embryo. Then subsequently it starts coming back into the body. So by 10 weeks, most of them start migrating back, and with the varied degrees of rotation. And by the 12th week, they do go back to the in the abdominal cavity or the peritoneum. This entire channel where the guts come out is usually covered by this umbilical coelom, or which is further encased with the Wharton jelly. So what happens? If it fails to return, then also the child may have the gut protruding out from the abdomen. So these things, which is umbilical coelom or the failure of midgut to return back into the abdomen, can be associated with the defects in the anterior abdominal wall. The other hypotheses which are proposed are failure of mesodermalization. It means that when the gut goes back, the covering fails to develop properly, then this may lead to the defect in the anterior abdominal wall. Or when there is decreased flow in the omphallomesenteric artery, which leads to the what we say the weakness in the abdominal wall and may give way area or a giveaway produced at that site from which the gut comes out. So of the two that I told you, most common are the omphalocele and the gastroschisis. For gastroschisis, where the entire gut is out and exposed to the outer abdomen, outer environment, that is gastroschisis. And most common risk factors that have been documented with it are young maternal age, low socioeconomic status, poor maternal care, primigravida, poor nutritional factors, and to an extent some vasoconstricting agents like mother uh, may have the abusive tendencies for various drug products or sorry. The another important the risk factors for omphalocele are the advanced age for the mother and maybe very young age for the maternal age. The maternal obesity is another factor, nutritional factor where specific deficiencies for vitamin B12 and the folic acids have been documented, or IVF. The genetic and the familial occurrences and the associate congenital anomalies are mostly seen with the omphalocele or exomphalos. So trisomies are seen with that. There are specific genes which have defects. The associated syndrome with the Backwards-Widman syndrome. So and the most commonly associated anomalies is also seen with the omphalocele, and most of them are cardiac and chromosomal anomalies. While with the gastroschisis, which have very less of associated anomalies, and of the associated, the most common are gastrointestinal, where they may have associated atresias, volvulus, and malrotation. So coming to omphalocele. Omphalocele means part of there is a defect at the navel site where the entire umbilicus has a defect. So what happens during the gut rotation period, the entire bowel comes out and this entire umbilical coelom fails to return back to the abdomen. So usually what we see that in omphalocele, the umbilicus is noted as a part of sac and has herniated abdominal contents in the sac. So the sac is covered with the layers of umbilicus, where there may be upper layer may be of amnion, which is the exposed or the intrauterine covering part of the fetus in the womb, and followed by a Wharton jelly, then a peritoneum, which is layer for the fetus. So these three layers form the part of this sac, and mostly this is a defect which is from due to the lateral folds. When the child has a lateral fold imperfect migration, then most commonly they present with omphalocele. Also, that as I was discussing, the other two folds are also there. If there is defect with the cephalic fold, or you can say the superior fold, then along with omphalocele, they may also have pental. This is pentalogy of Cantrell, and also there may be ectopia cordis. While if there is a defect in the caudal fold, or you can say distal inferior fold, then they may also have cloacal extrophy associated. While for the gastroschisis, as you can see in this picture, the entire bowel is exposed and lying freely outside the abdominal cavity. and it has not got any cover over it. So in when this thing is present inside the womb, then the entire bowel is exposed to amnion, due to which there may be some changes already setting in the bowel. And while at birth, when the child is born, this entire bowel become exposed to air, and then subsequently it starts desiccating due to dehydration. The bowel becomes thick, matted, there may be edematous, and due to uh, release of exudate, there may be fibrinous peel, and which leads to adhesions in later on. So as you can see clearly in this picture, the gastroschisis has umbilical cord right to it. Sorry, it is right to the umbilical cord. So umbilical cord is not the part of gastroschisis. It is attached to the abdominal wall. So it has been proposed mostly, as I was telling you the last theory, that there may be a defect in the abdominal wall which gives way, from which the bowel comes out. So this is where we can see the umbilicus is well attached to the abdominal wall, and the entire gut is out from right to it. These defects are usually small and less than 4 centimeter. And in this, as has been proposed, the umbilicus is well centered. It has been noted that the bowel at one point of time during the entire growth or intrauterine development of the child must have been inside the abdominal cavity. So it is said that the patients with gastroschisis have a better abdominal cavity when compared with that of the omphalocele. So this is an important criteria, or the what you can say, the differentiating features for omphalocele and the gastroschisis. While gastroschisis is more common than omphalocele, omphalocele can be diagnosed at an earlier antenatal period when in comparison to gastroschisis. The sac is always present with the omphalocele. The defect is located at umbilicus, while with gastroschisis, it is right of the umbilicus. Trobosomal anomalies are more common with the omphalocele, while intestinal anomalies or the gastrointestinal issues are mostly seen with gastroschisis. Prematurity is a feature of gastroschisis. These children are born at a very early stage. They have high alpha fetoprotein, and the prognosis mainly depends upon the condition of the bowel for gastroschisis, while for omphalocele, we have to look for associated anomalies and the defect. The other entities which can be associated, which are part of anterior abdominal wall defects, are umbilical hernia of cord, which is a very rare event, and there is only midgut coming out of the umbilical cord. This entity only holds importance, especially for the person or the physician which is clipping the umbilical cord. So one has to be very sure while clipping and twisting the umbilical cord that it should not contain any abdominal content. The other is the true absence of abdominal wall, where the entire bowel or the abdominal structures are just lying outside, and there is no abdominal wall, none of the fold develops. So this is a condition which is incompatible with the life. Another very well-defined syndrome is of the prune belly syndrome, where there is deficiency of the muscles. So for anterior abdominal wall defects, the most common investigation is ultrasound, which is antenatal ultrasound. So these children present or come to us in the clinic, where the mother brings their antenatal ultrasound and asks what should she be doing. So as was discussed, the omphalocele can be diagnosed at an earlier antenatal period, while gastroschisis may be diagnosed by 18 to 20 weeks. So by over and all, By 20 weeks, we may have a diagnosis of antenatal diagnosis of anterior abdominal wall defects. They may have associated polyhydramnios. There may be presence or absence of sac depending upon the condition. One has to look at the content of the sac, and also associated bowel dilatation. Bowel dilatation is mostly seen with the gastroschisis, where the bowel is exposed to amnion and the changes are taking place or the edema is there. So, most important concern of the parents is whether they should keep the child or not. So, if the diagnosis is made by 20 weeks, one has to counsel likewise. So, whether the we have to plan whether we have to terminate the pregnancy, or if they come late, then we have to guide the pregnancy along its course. So if they come early, less than 20 weeks, then termination can be set. And if they come later, then depending upon the child's condition, or if there is polyhydramnios, or there is massive bowel dilation, one has to plan for amnio exchange, so as to remove the excreta or the amniotic fluid and replenish it with a clearer amniotic fluid. Normal delivery and cesarean, they depends upon the treating the gynecologist, whatever way she wants to go at her center. Most, as was said, the gastroschisis deliver preterm, so one has to be ready with the basic neonatal or the skilled neonatologist. So when they present or when they are born, one has to look at the entire birth defect, condition of the bowel, what is the size of the defect, what is the condition or the associated anomalies with it. So most of these children are often intubated in the delivery room, or maybe just managed in the delivery room. One has to be aware, they should make sure that these children are preterm, so have to preterm or the premature, so they have to be managed on that guideline as well. As far as the surgical part is concerned, we have to make sure that the child should be, gastric decompression is being done, so NG tube is placed. Hydration should be well maintained. As the bowel is exposed, the child is losing the water and the salt, it has to be replenished properly. The exposed bowel, specifically with the cases in the gastroschisis, it must be covered with the saline gauze. It should not be left exposed to the upper surrounding or the abdomen, and it should be minimally handled. After placing the moist gauze, one can cover it with the cellophane so as to avoid water evaporation or water release from the bowel. These children may end up with hypoglycemia, so they have to be managed accordingly. Due to the larger exposed area, they will have hypothermia, which also should be managed properly. So when it comes to the surgical management, we can go two ways. Either we go for the primary reduction or the stage reduction. Primary reduction can be again be done in the two ways, where the child may be taken up for surgery under general anesthesia, where the bowel is subsequently reduced into the abdominal cavity and closed. In very rare cases, a cord-side primary reduction has also been attempted, but it has to be done immediately at the time of birth. When the child is born, the bowel is very soft and is not matted, not edematous. So there and then an attempt to reduce the bowel can be done. However, not in all cases primary reduction is feasible. What happens when you replace the entire bowel in the abdominal cavity? There will be increase in the intra-abdominal pressure. So one needs to monitor that also. Otherwise, what will happen? The entire system will shut down. There will be decreased lower flow, lower blood flow. So the child will have baggy legs, edema will be there, hypovolemia will be there. So one has to be very watchful for the abdominal hypertension. So for those cases, we have to go for stage reduction. Stage reduction again can be done in two ways at the cot site. If the child is sick, one must prepare for subsequent reduction. So what you can do, that preformed silos are there, and silos I'll be showing you the picture in the subsequent slide. Or especially in cases of omphalocele, the entire omphalocele sac can also be put under traction. While the other stages are the for those you can take the child in OT. In OT you can properly make a silo, attach the silo with the abdominal wall muscles in the or the fascias. And in cases where it is not possible, or where you can see that the bowel contents can be reduced, then you can just put a skin cover, and this skin cover will help you to make a ventral hernia, or it is iatrogenic ventral hernia that is made. The another important feature is the prosthetic material that you can use to oppose the abdominal wall. So silos, as I have been telling you, in this you use materials like skin covers can be used, prosthetic patches can be used, and the giant omphalocele sac can be used. Okay? And there are various materials available these days, even the biomaterials, from which the silo can be made. After taking the child to the OT, you have to clean the bowel, give some warm compresses or warm cover to the bowel so that edema subsides. The bowel, as much as bowel can be replenished into the abdominal wall, that should be attempted. Then a silo is formed. And important thing is the silo should be placed against the gravity. So what happens? Subsequently, this silo provides different type of forces, like that of with the gravity, the bowel will be coming down to the abdominal cavity. By the side, there will be traction onto the anterior in the abdominal wall, which will allow it to settle in. Also, the dilated bowel will subsequently the edema will subside, so it will make more space. So there will be expanding capacities also along it. So when you place it upwards at this point of time, as you can see in this, the ring is placed and it has been lifted up. The gravity plays its role. Here the attraction is applied onto the entire abdominal content, which subsequently goes down. The attachment to the fascias will provide a lateral force, or you can say a expanding force. As the bowel edema settles, then also the bowel comes into the abdominal cavity. So mainly these four functions work when you are talking about silo. The off-shelf abdominal wound retractors are being used, which is just placed under the skin and traction is given. Another important method that is being used is a paint and wait method, or escharring technique. So this is one of the non-operative management of our exam fellows, when we have sacs which we paint with the sulfur, the silver sulfadiazine or the alcoholic mercuric paint. So what happens is that the entire sac, it starts desiccating, granulation comes over it. Then subsequently from the sides like this, epithelialization starts, and a time comes when the entire sac gets covered with the epithelialized skin. However, that may not be a very cosmetically acceptable skin, but yeah, skin does come over it, but it takes time. So this is another method which is being done, but only done for exome fellows where the bowel is not exposed. So as I told you that we make ventral hernias, which we can close later when the child grows, maybe in a year or two, and by utilizing various flaps that are available, like the rectus flap, or using aponeurotic transposition methods, or latissimus dorsi free flap, or applying tissue expander into the skin, which provides an extra skin to cover it. So it has been noted that for these children with abdominal wall defects, mostly the bowel obstruction is seen with the cases of gastroschisis, which is around one-fourth of them have this condition during the follow-up and may require laparotomy or the reoperation. And 85% of them have sepsis, facial adhesives, which may not only risk the life of the child, but may also have a poorer prognosis or the poor sequelae. The gastrointestinal functional disorders are seen in mostly half of the patients with gastroschisis. As the bowel is exposed to the outer environment in cases of gastroschisis, there are changes which have already started setting in since the in utero life of the child. So it is very difficult to get a normal bowel which is for a normal child is exposed only to the peritoneum, while for the gastroschisis it is exposed to the amnion, where they may have the excreta discharge, or excreta, or you can say the urine component also, because amnion is predominantly made up of child's urine. So they may have high contents of urea, which may also derange the bowel, what you can say, characteristics. Nutritionally, they are said to be doing fine, especially the cases of exomphalos, while for the cases of gastroschisis, where they may have associated intestinal disorders, most of these patients turn out to be short bowel syndrome, or may have this due to functional disorders. Gastrointestinal disorders may be the candidate for intestinal transplant and may not tolerate normal feeds or normal diet even till the late stages. Mortality has been noted to be ranging from 8 to 25% in both the cases of gastroschisis and exomphalos, more so for the patients with the gastroschisis, and the reasons being antenatal death or termination, then the neonatal death or the early death, and then the late death with the bowel obstructions, intestinal failure, or associated liver diseases. And a very small chunk may also have their mortality associated to the anomalies they have. So it has also been noted that when they have early gestation or preterm, they are more prone for as a morbid group. So that's all for the today's class. So do you have any doubt in either of the topic, in abdominal wall defects or biliary atresia, then you may bring up? Do you have any questions?
No, ma'am.
No questions. So finally, any one of you got what I was teaching, or it was all going above head? Okay, all the best for your exams.
Thank you, ma'am.
Okay.
Thank you, ma'am.